All right, Gil, can you hear me?
I can. Good morning. How are you?
Good afternoon, Gil. I'm fine, thank you. How are you?
Excellent.
All right, so we've already got a couple of questions in the chat box on YouTube. That's good. But before we start, I want to welcome everyone. And we're going to take first some questions that were already prepared. And I've also got the 20 rapid fire Q&A that I did with Dr. Angela Service recently. So we're doing the same with Gil as well, since everyone has a bit of their own, their own light on things. All right. I've got them in front of me now. All right. So Gil, let's start. So very general, basic questions for TRT newbies, but maybe they want to have a lot of information in a short amount of time. So let's go. What are the benefits of testosterone replacement therapy?
Well, the benefits are replacing a deficiency, right? If you have been diagnosed with a deficiency, keeping this short without going into all the signs and symptoms of the deficiency. Essentially, by replacing them, you're going to negate all of the ailments that come along with the deficiency and potentially prolong and improve the quality of your life. So we can go into far more detail about what each one of those means, but in a nutshell, we want to arrest and potentially reverse any adverse effects of testosterone deficiencies.
Right. So what are the risks and side effects of TRT?
Well, the risks are higher when done incorrectly. So the first step anyone should consider is finding a competent provider who truly understands hormones. Just because they advertise that they do does not mean that they do. Channels like this are a godsend for anyone who is new to this field and wants to do a little bit of research before they go on their own journey. So I do advise everyone to find the correct provider, and then all of the education and proper treatment management will follow suit, because again, we can spend an hour discussing risk versus reward, but the goal here is to stave off any risks and side effects, and obviously just benefit from the upsides of treatment.
All right, question 3, is TRT for life?
Is it for life? It should be. It doesn't have to be, okay? No one's going to die if they come off testosterone. We need food and water. We need air. We don't need testosterone per se to remain alive, but we do need testosterone to remain alive with a good quality of life. So if you went on for the right reasons, which is to treat and reverse a deficiency, that deficiency will not self-correct on its own, especially as you age. It's only going to get presumably worse. So the goal of a deficiency, just like if you were insulin dependent, you'd be on insulin for the rest of your life, although you would die if you didn't have your insulin. With testosterone, it's not quite as drastic, but you certainly want to replace it for the rest of your life.
All right. How many times per week will I have to inject?
Again, that's going to come down to several factors, including your SHBG and other binding proteins and lifestyle, metrics. But that's for your provider who, again, if they're competent, they're going to advise at the bare minimum. If you're using testosterone cypionate, the bare minimum is twice per week in a minimally invasive protocol, which I have made a video on our clinic's website, video number 68, which is a 2-minute video teaching you just how simple it is to self-administer at home.
All right. What is the best TRT dose?
Dose, again, there's no cookie cutter approach. That's going to come down to you and your provider managing you correctly. Dosing is very specific. With any medication, there are specific doses that are designed for different individuals. With hormones, it's even more multifactorial than just height, weight, etc. There are other factors that go into it. There's cascades of upstream hormones, downstream metabolites, and whatnot. So everything should be taken into consideration. Full subjective assessment should be performed. Objective data should be considered, and then feedback from the patient on evaluation should also be considered. So dosing is something that is tailored for an individual and is adjusted on the fly throughout the course of treatment.
Mm-hmm. What if I don't want to inject? Are there any other good options?
So testosterone compounded cream, not to be confused with gel, is a viable option, which I believe you yourself have been using for many years. Personally, I'm not the biggest fan of cream, as we all know. I do prefer the injectable protocols, but anecdotally, cream has been shown, when done correctly and dialed in, for many individuals to work quite well. Outside of those two options, excuse me, I really would not consider any of the other forms. Jatenzo, which is a name brand oral, absolute junk. 1.62% alcohol-based gels, absolute junk. Pellets, complete and utter junk. Any of those administration, now they even have a nasal spray, any administration form short of a compounded cream and an injectable form of testosterone, I certainly would not consider or recommend for anyone.
What's the best spot or site on the body to inject TRT?
So my video teaches how to use the lateral delt. Okay, and then the ventral glute is also a very non-invasive, minimal pain area. It's fairly avascular, not a lot of nerves that run through the area. It's a nice little pad there. And if you use a 27-gauge half-inch insulin syringe in both of those locations and you rotate left to right, you could do this for the rest of your life. Minimal scar tissue, if any, and like I said, no pain and occasional minimal bleeding, if any.
Mm-hmm. You already answered, but what's the best needle to inject TRT?
27-gauge half-inch, bar none. If you watch video number 68 on elevatewellnessgroup.com under our knowledge base section, there is a demonstration of it. It's a 2-minute video. Everybody should be able to access that for free.
Another question that keeps on returning, are sub-Q injections as good as IM injections?
There have been studies suggesting that they were. What I will say is don't worry about it. Inject on a 90-degree angle with a half inch. And if you happen to, get into a shallow muscle or a deep sub-Q, the absorption rate seems to be fairly similar. I do not recommend belly sub-Q or 45-degree sub-Q injections. They do tend to nodule up a little bit and take time to dissipate. Absorption has not been shown to be quite as efficient as intramuscular due to, again, in relatively avascular tissue in adipose layers. So I would recommend watching video number 68 and addressing it according to the way the video shows.
Mm-hmm. After starting, when will I have my first blood check?
Every provider has their own protocols. In my office, we like to go 8 weeks out. Testosterone cypionate, which, as you know, has a 7 to 8 day half-life, takes about 35 days to reach a steady state, which is 5. Basic pharmacology teaches us that 5 half-lives is a steady state in any medication. So 35 days to hit steady, about another 3 to 4 weeks of living in that state. So we can look at the objective data at day 35. We want to give you another 3 to 4 weeks to get proper subjective data once you've hit steady state. And that's when we do our reevaluation. It is a short enough period for us to assess and make adjustments. It is long enough for us to get a clear picture of what's going on with your treatment.
Mm-hmm. What's the best moment, how many days after or before the injection to have blood drawn for control?
So the rule of thumb, right, in medicine is that you always test a trough. So you want to test just before the next administration with a relatively medium acting ester like cypionate. If you're frequenting correctly, which is 2 to 3 times per week on average, depending on the individual. And as we know, some individuals with low SHBG microdose daily, you really should have pretty steady state throughout the entire week. So I tell my patients it's really irrelevant when managed correctly, and you can really get your labs drawn at any time, because we're trying to avoid peaks and troughs, right? We want like a nice little sawtooth graph and not these peaks and valleys, because hormonally we don't want to send people into a cycle of feeling great and then crashing. So we try to aim for that, level where they feel their best, and they just move the bar up and down laterally.
Mm-hmm. What's the best time of day to inject TRT?
Find a time that's convenient for you, stick to it, and create a habit.
Mm-hmm. What if my hematocrit is high? Do I have to donate blood?
You do not. So Dr. Rouzier has a great piece on this. And again, it's a little lengthy, so I won't go into great detail. I will say hematocrit is merely a dilution ratio. We can improve dilution ratio by hydration. So if you hydrate better, your hematocrit will come down, even without affecting any change to RBCs. Remember, most people go into a lab draw fasted. And for layman's people, the word fasted means NPO, or nothing by mouth, for 8 to 12 hours. So make sure you drink, at least 2 of these 17-ounce bottles prior to your blood draw. You don't have to eat food, but you do want to drink water so that the blood flows smoothly and that your hematocrit presents a true and accurate number rather than a dehydrated number, which is often common in the morning.
Also, a question that many beginners have asked, do I have to take anything else on TRT? Vitamin D, DHEA, pregnenolone, magnesium, and if so, who will tell me what and when?
So TRT and proper nutrition are mutually exclusive. Whether you're on TRT or not, you should replace any deficiencies. Most people who live in America, at the very least, and I would imagine Northern Europe as well, are vitamin D deficient. So a good D3, 5,000 IUs per day is a nice, average dose for sustainability, which is, by the way, about 2.5 times the recommended USRDA, which is completely outdated from the 1950s. You couple that with a K2, which helps absorption, unless you're contraindicated with a blood thinner. Other than that, there, zinc, magnesium, vitamin C, we can go down the list of essential vitamins and minerals and spend 45 minutes discussing that. But at the end of the day, whether you're on testosterone replacement or not, you should address whatever vitamin, mineral, and nutrient deficiencies you may have as a result of malnourishment.
Mm-hmm. What if my estrogen is high?
There's no such thing as high estrogen in men if your testosterone is optimal. Okay, so if you have optimal testosterone level, estrogen in men and in postmenopausal women as well is not an endocrine hormone. It is a paracrine and intracrine acting hormone. It is aromatized or converted or reduced within the cells of its target tissues, and serum levels are merely excreted hormone. 85% of estrogen in men is excreted via urine. That means it circulates through the blood into the kidneys and eventually is urinated. So we don't even test estrogen serum levels in our men. We have thousands of patients doing very well for many years. None of them on our aromatase inhibitor or have their estrogen levels checked at all once testosterone is optimal.
Clear. Is TRT bad for the heart?
No, TRT is actually very cardioprotective, and one of the cardioprotective properties is the metabolites such as estradiol, B17, 17 beta estradiol specifically, is extremely cardioprotective. It's been shown to help to regulate endothelial function in veins and arteries. It is protective of muscle tissue, smooth muscle tissue, cardiac tissue, and the risk of MACE or major adverse cardiac events has been shown to be reduced when men have optimal testosterone levels. In fact, a study I've looked at recently, which I've seen years ago and then recently popped up again, was how low testosterone greatly increased the risk of cardiac events. So optimizing correctly without the use of aromatase inhibitors, without the use of incorrect frequencies, and utilizing a good provider who truly understands hormones actually will greatly increase cardiac health.
Mm-hmm. Sure. Will TRT increase the risk of prostate cancer?
So Abraham Morgentaler, as you know, is a prominent urologist out of Harvard Medical, and he's published many papers, I think over 20 papers in the last 5 years from Morgentaler, specifically relating to prostate cancer and testosterone replacement therapy. Now, as you know, urologists have always used something called ADT, which is androgen deprivation therapy. It is essentially chemical castration for men on active surveillance or with prostate cancer. They believe that DHT, which is dihydrotestosterone, the second prominent metabolite of testosterone after estradiol, which is converted via the 5-alpha reductase enzyme, that it was responsible for the enlargement of prostate, benign, BPH, and whatnot. So, in fact, he's proven via various literature and studies that DHT and testosterone do not increase the risk of prostate cancer, do not proliferate or exacerbate existing prostate cancer, and he actually continues TRT treatment for his patients while on active surveillance. So the short answer is no. And the literature is out there supporting it.
Mm-hmm. Will TRT make me go bald faster?
Well, that's a funny question coming from you, right? The short answer is no.
I was bald before TRT.
Exactly. So look, I've been on TRT for a decade, right? I haven't lost a strand. I will say that if you have the male pattern baldness gene, which is a genetic predisposition, it comes from your maternal grandfather. So your mom's dad, presumably, is where they found the gene lineage. If you have the male pattern baldness gene, you're going to lose your hair, and it is inevitable, and there's nothing you can do about it. No amount of 5-alpha reductase inhibitors like the Steroid, finasteride, etc., can prevent it. DHT will potentially accelerate the rate at which this occurs. So if you were going to lose your hair at 50, you may lose it at 45 when your testosterone is optimal. With that said, it's a phenomenal trade-off, if you ask me. Again, it doesn't cause it. It does not necessarily make it happen if it wasn't predisposed to happen genetically, but it will potentially, not guaranteed, make it happen a little bit sooner. If you're going to utilize a medication to help stave that off or delay, like finasteride, you are at risk of suffering what's called PFS or post-finasteride syndrome. Again, a whole nother topic we can spend a lot of time on, but I suggest you Google post-finasteride syndrome and avoid any such medications.
I was searching for a picture of my grandfather. I have found it already. Yeah, so this is my grandfather, the father of my mother. My mom died. He died a long time ago, but he was bald without TRT, of course.
You guys are twins. You're just more muscular.
Yeah, well, he was pretty muscular himself when he was young, but there he was 60, 65. So, all right. Last questions there. Will TRT solve my sex drive and erection problems?
Will it solve it? Well, again, multifactorial. If the state of low T is what led to those problems, and this is a big and, if those problems have not been ignored for many years, where they potentially went from a hormonal issue or an endocrine-related chemical issue to a physiological occlusion, which does occur with neglect, then potentially the answer is yes. If there are other underlying factors and comorbidities that potentially may lead to these conditions, then simply replacing the underlying factor of low T, while healthy and certainly may resolve other things, you may not reverse all of the manifestations that started with low T. Again, the longer you wait to replace it, the less likely things are to go away without further intervention. So the short answer is maybe, and again, this is why you need a proper evaluation by someone who truly understands what these dysfunctions mean, how to fix them, and how they correlate to proper hormone treatment.
Mm-hmm. Last question. Will TRT help me lose fat and build muscle?
The only thing that's going to help you lose fat is the laws of thermodynamics, okay? You need to be in a negative energy balance. You need to train properly. You, as the author of a book specifically on nutrition and training, obviously know this as well as anyone. Whether you're on hormone therapy or not, it still comes down to negative energy balance in order to generate lipolysis. Testosterone will improve base metabolic rate. It will improve protein synthesis and the rate at which your muscles can process the nutrients that they are given and recover. With that said, you'll be able to train more intensely. You'll be able to likely eat more food and still have more of it processed towards muscle. So will it help in a general sense? Yes. Will it help if you're laying on the couch and watching TV? No, that is a flawed approach. You need to still put in the work. You need to put in the effort. You need to be properly educated on proper nutrition. You need to define your goals, and you need to draw a plan backwards in order to meet them. If you don't have a blueprint, don't expect to build a big house.
All right. Okay, thank you, Gil. Those were the 20 rapid fire questions. So let's put the chat box here up the screen. Let's try this. Share screen. I hope this is the chat box. Is this it? Yeah. All right. Yeah. So these are the questions already there. I will read them out loud. What is the easiest insulin syringe, gauge, and needle length to draw test SIP? I got a 29.5-inch needle from Walgreens, and it was difficult to draw the oil.
Watch video number 68, elevatewellnessgroup.com, click on knowledge base. I like 27, 29 works too. Video 68 will solve your problems.
Gil once said you are chemically castrated if you are using androgel. What's the difference from being on any other form of TRT? Are you not also chemically castrated on shots?
No, you're not. Because while you're shutting down the endocrine function of endogenous production, you are sufficiently replacing it. Androgel fails at replacing. This is the problem. I never said that one is suppressive and one is not. I merely said you're castrated. So you're suppressed and you fail to replace. That's the difference. If I fire you from your job and give you another job that pays more money, you don't go broke. But if I fire you from your job and don't replace your job, now you're broke. And that's the difference.
Mm. I'm on TRT and getting red eyes and puffiness under my eyes. I think it might be, I'm worried it might be kidney function. Does TRT affect the kidneys?
No. Testosterone, properly administered pharmaceutical grade testosterone is not nephrotoxic whatsoever. Now, with that said, if you have hypertension, if you have some sort of existing renal disease, and you are now eating a diet that's high in sodium, and you are retaining water, and your blood pressure is not being properly controlled, then certainly you are causing renal failure. And testosterone will impact the kidneys only in a sense of increasing aldosterone, which helps to reabsorb sodium in the renal tubes and therefore retain more water. This could be transient. It could also be cleaned up with a proper diet. So directly, no, it does not affect the kidneys. Indirectly, if you lead a shitty lifestyle, then you got to fix it.
Labs every 3 months, having increasing my hematocrit by 3 or 4%. Blood pressure is good, platelet counts normal, hematocrit is at 55%. Baseline before TRT was 48. Would switching to sub-Q help reduce it? My protocol is 50 milligrams twice a week.
You don't need to reduce it, number one. Make sure you maintain hydration. Make sure you're not hypoxic. If you have obstructive sleep apnea, if you're a smoker, if you have any of those conditions, address them first and foremost. Secondly, if your platelets are normal, there's no coagulation risk. It's an expected finding, and in most cases, a welcome finding. It just means you oxygenate better. So look at your MCV. Make sure your red blood cells are at an optimal size so you can carry sufficient hemoglobin. And if you have microcytic or macrocytic anemia as a result of MCV being out of whack, then address the deficiency, whether it be cobalamin and folate or iron and folate. But again, if you have a competent provider, they should be advising you on this, and they should already be well ahead of the game on that.
Mm-hmm. Hi, David. Thank you for watching. As we know, David says, as we know, high estradiol on TRT, if you have no side effects, is not a problem, and it's actually good for your health. But some say that high estradiol can increase prolactin. Is that true?
So there's no such thing as high estrogen side effects, so to speak, or symptoms. I mean, again, if your androgens are optimal, then estrogens are self-regulated. Does prolactin move in tandem with estrogen levels? Presumably. However, prolactin is extremely transient. It elevates greatly after an orgasm, for example, and then it comes back down. So if you're not symptomatic for high prolactin, leave it be. And if you are, again, don't worry about the lab ranges. Those are designed for the average population, which are not on treatment. So, if you're triple the high end of the range, prolactin's 40, 50, then assess what's going on. And you can use, a little bit of P5P if you want to try to reduce it in a non-pharmacological over-the-counter way. If your prolactin is extremely elevated, like 100 plus, then you should be referred for an MRI and rule out a benign pituitary adenoma.
Right. A lot of thank yous. Happy Saturdays. A lot of complaints about low libido, but you should mention your protocol. David again, for blood analysis, is it advised not to work out 3 days before? So that means that testosterone will be higher during this period than during workout days. So we have to take this into account, right?
No, if you're on treatment, stop worrying about your testosterone levels and your workouts. So just live your life and enjoy. The only thing that a workout is going to affect is if you're running a CMP, your ALT and AST are going to be transiently elevated. And again, a competent provider is going to expect and understand this. So it's a non-issue. And don't try to time your workouts around your blood draw. Just live your life. And essentially, when we do run your labs, we want to see a true and honest picture of what's going on. We don't want to manipulate labs to look differently than the other, 3 or 4 months where you're not doing labs. We're essentially doing labs to grab a snapshot of what is going on in your body. And if you manipulate that, then the entire point of drawing a lab is flawed.
Mm-hmm. Yeah, I understand. I've been on TRT for 5 years. I've been feeling worse over the past year, like on too much and not enough at the same time. Wanted to try HCG. Any recommendations for dosing?
My recommendation is address this with your provider. And if it's taken them a year to address this, then you should be seeking a new provider. It's quite possible that the way you feel is unrelated to your therapy, and it is possible that it is related to your therapy. And without knowing anything about you, your previous medical history, and your therapy, it's an irresponsible question to try to answer specifically, but the general answer is your provider should address it correctly, or you should seek a new one.
A question that keeps on coming back. Why do you say that testosterone 1.62% in alcohol form is junk?
Well, because it's non-esteroids, it's in your body and out very quickly. It fails to replace sufficient levels. Remember, it was designed in urology to get you to a level of about 400 to 500 total testosterone. It gives you no opportunity to manage or control low SHBG, and most Americans are pre-diabetic or insulin resistant and have low SHBG, and therefore it's really a problem when you try to optimize these guys, and it's a struggle. And with injections, we have so much more control over their protocol. We have so much more of a half-life to work with. I mean, these guys excrete so quickly. And when you 1.62, I mean, the cream that you're on, even though it's a transdermal, I believe it's 20%,
20.
right? So you have 200 milligrams per gram or per milliliter. 1.62%. I mean, you're looking at something that's 17 times weaker than the cream that you're using. It's just flawed, period. I mean, we get guys with Androgel transferring it all the time. They never feel well. They're never optimal. As soon as we get them going on the proper protocol within 8 to 12 weeks, it's like a whole new life.
Mm. Good morning, gentlemen. Shannon Saunders says, my husband is a smoker. Can he take TRT?
He can. I won't treat smokers. I mean,
Really?
I'm sure. I mean, it's not contraindicated, but he's going to struggle. He's going to struggle to optimize. He's going to struggle to maintain, a good H&H long term. He's probably kind of on the higher side before as a baseline. And again, we know that H&H specifically is not an issue, but the medical community as a whole has not accepted that concept yet. And they still litigate over it, and it's still an uphill battle to try to look at the latest studies and convince people. But Rousier is putting out a lot of stuff on this, and over the course of the next decade, hopefully it'll become more mainstream and acceptable. But for the time being, it's still an uphill battle. Personally, I won't treat a cigarette smoker because I find that if you're going to come to us and look for optimization, you better want it more than we do for you. So if you're going to self-sabotage and you're going to do things that are, drastically decreasing the quality of your life and your health, that's not something we're going to reward with a drug or pharmacological interventions. So this is our personal views coupled with the fact that we've managed smokers and they're extremely difficult to dial in. So that's my answer on that. Not with us, but I'm sure someone will manage him. And yeah, technically it's not contraindicated, but it's going to be an uphill battle.
Mm-hmm. Is there any data showing if testosterone increases serotonin levels high enough that it could replace a high dose SSRI?
So testosterone does modulate neurotransmitters. We do know this. We also know that it has neuroprotective properties. We know that all age-related ailments, including dementia and Alzheimer's, are essentially staved off or delayed when men are optimal. We have seen in studies that men develop these, neurological deficits faster or at a younger age when their testosterone levels are lower. So replacing an SSRI is a little tricky because they do build up dependence over time. But yes, the short answer is we have seen men who are optimal on testosterone after 6 to 12 months or longer eventually taper down or completely off antipsychotics, anti-anxiety medications, certainly. Because remember, a lot of them are overprescribed because their basis of low T symptoms are often masked with, hey, here's a Prozac and a Viagra, have a nice day, your testosterone's normal, because their PCP just tests for total T. And they don't realize that in older guys, elevated SHBG leads to artificially higher total T. So when your T comes back at 500 in your 50s and they tell you, oh, your testosterone is great, you must be depressed, here you go, you should have never been on an antidepressant. They should have assessed your testosterone correctly because you're symptomatic because you have no free T, secondary to elevated SHBG. But again, I don't expect the primary to know that. I don't even expect an endocrinologist or urologist to know that because, quite frankly, they all suck at treating hormones. And it's a damn shame, but that's why guys like us are needed. It's not just to treat, it's to educate. So maybe they'll come around and understand proper hormone management so more providers can offer more services to more people.
Mm-hmm. In the previous video, Gil talked about a PCT protocol, but did not say any dosages for HCG and tamoxifen. Can you give a rough idea of doses and length of these doses, please?
Yeah, I reserve specific protocols to patients. There are protocols that work well for some guys and not others. It really comes down to your original diagnosis, right? Was it pituitary hypofunction? Was it testicular hypofunction? Because if you have strong testicular hypofunction, or strong primary hypogonadism, HCG is not going to work on you anyway. So really after a proper assessment, we come up with doses and protocol options but we do reserve those for our patients, rather than putting out blanket statements. Blanket statements are dangerous. I'll never discuss absolute doses in a general setting because I don't want someone to follow a dose schedule and say, well, Gil said XYZ, if that's not the right approach for them, because I've never laid eyes or hands or anything on that individual. So we can't assess them enough to give a dose like that. So I can give general umbrella answers. I can't give you specific doses for you as an individual.
Can TRT help reduce OCD symptoms?
Probably not. And I'm living proof of that.
Mm-hmm. Shannon, I hear TRT has so many benefits of TRT therapy. What is your favorite benefit? What is your favorite benefit, Gil, and why?
My favorite benefit is mental clarity because I am a deep thinker. I can lay down for hours, close my eyes, and just get into my own head. And to me, our brain is really where our life is. Everything out here is just floating molecules and proteins, but your real life is here. And for me to be able to truly live in my own head and experience all of the mental clarity and enjoyments of what your brain has to offer you, personally, to me, that's everything. The added energy and drive and push and all that in the outside world is great, but the inner clarity and the lack of brain fog and the lack of negativity in your head, for me, is a game changer.
My PSA went up from 5.2 to 7.9, free PSA 19% 2 months after starting testosterone. Total test starting 65, 2,200 free T 35, 100 milligram split 3 times. Is this common?
It is common to have a mild spike in PSA post-therapy initiation. PSA, again, just like hematocrit, is extremely transient. I tell all patients to refrain from all sexual activity for 72 hours prior to a blood draw. Also refrain from perineal pressure. If you ride a stationary bike, motorcycle, anything of the sort, anything that puts pressure on the perineum will transiently increase PSA values. With that said, slight increases are expected. If your PSA was a 5 prior to starting, you should have had urology clearance prior. So maybe you should go and get a prostate exam or a DRE. Please do not let them biopsy you. They're very quick to do that immediately. They'll have a PSA reading that's high. They'll biopsy you instantly. Once you poke a hole in the prostate, it is not the same. You're going to suffer severe and often irreversible sexual dysfunctions. So don't go poking holes in your prostate unless it's absolutely mandatory. Get all of the digital scanning done prior and fully rule out any risks of cancer. And if they're unable to, then last resort should be a biopsy. But I've literally had guys go from a PSA of 2 to 6, and they call me and they say, oh, I have a biopsy scheduled next week. These urologists, forgive me for saying, some of them are butchers. I realize they only get paid when they hold a knife, but stop cutting up guys' prostates for the sake of diagnostics when there's so many steps that you're skipping, and you're relegating these guys to severe trauma because they end up in my office with really, really bad and often irreversible ED, and then they have to be on intracavernosal injections for the rest of their life. Mm-hmm. So please do not run out there and get a biopsy unless absolutely necessary. And again, 2-point increase, that's not a drastic velocity change. I would say refrain from all of the activities I mentioned earlier for 3 or 4 days. Go back and have a redraw and see how it trends. It may come right back down to baseline.
Gil, what's your thoughts on Dr. Braunstein high-dose iodine therapy?
So I'm not familiar with the individual in question, but high-dose iodine, iodine promotes T4 in the thyroid. So, what is the basis for the question? Are they asking my thought on thyroid or and again, define high dose. What's the purpose? Hypothyroidism?
Yeah, Umar Malik, give us those details. We don't know who Dr. Braunstein is. What does Elevate charge for someone who lives in Florida, currently paying $3 a month for test C, but PCP is going to strangle me at my next appointment, trying to keep within a budget?
So what was the question about it?
How much do you charge for someone who lives in Florida?
I don't get involved in money. That's my office staff handles all the money. I don't touch or see money. I look at it once a month. I don't know. I mean, the best thing to do is, if you have interest, go to elevatewellnessgroup.com and just put in your name, email, and phone number. And on Monday, someone will give you a call and you can ask them all the questions in the world, and they'll have that information for you.
What form of vitamin K2 is best to take with D3?
What form? I mean, are they referring to brand?
No, there are different forms of vitamin K2, no?
I mean, the one that we carry in our office is a D3 and K2 combo. Combo. They're mixed into one. It's 5,000 IUs of D3, and it is 180 micrograms of K2.
Mm-hmm.
And that's the only form I'm familiar with.
Yeah. If I'm not mistaken, sometimes on the bottles it says MK7. I don't know.
It's possible. While I know supplements, I'm not going to sit here and pretend that it's my area of expertise. I think Dave Lee would be a better person to inquire about supplements.
Yeah, we'll ask him next time. All right. You mentioned that MCV should be analyzed in relation to hematocrit. My MCV was 92.8.
That's
Does
fine.
frequency of administration have a profound effect on CBC marks?
CBC marks, yes, but CBC is quite broad. You have your CBC, then you have your differential. And, primarily what testosterone in general is going to affect is RBC, hemoglobin, and then by way of that, hematocrit. MCV less so, although if you take up a lot of iron as a result of increased erythropoiesis, sometimes MCV will come down and you may have to supplement with additional iron and folate. Again, this is a little more rare, but it's not uncommon. With that said, if your MCV is right in that 90 range, perfectly fine. Really not an issue. Me too.
If a person doesn't eat much calcium, can K2 cause issues with EQ and dopamine?
If a person doesn't eat a lot of calcium and what?
Calcium, yeah.
What's the question?
Can K2 cause issues with EQ and dopamine? I don't know what EQ is.
EQ and dopamine?
Yeah.
I'm not sure what he's asking.
Yeah, someone asks about cypionate with a 27-inch syringe for sub-Q in the belly, but Gil already said he doesn't like sub-Q in the belly.
No belly injections with oil-based medications. You're going to have nodules and slow absorption.
Is TRT effective if I have COPD emphysema?
Yes. However, prior to starting, have a look at your H&H, which is likely elevated secondary to hypoxia, right? And make sure that whatever treatment you are prescribed, whether it be oxygen, CPAPs, whatever the case may be, make sure that you utilize it to give yourself the best starting baseline. Because often people neglect an underlying comorbidity. They start testosterone and then they wonder why they struggle to optimize. So make sure that you're addressing whatever treatments are prescribed to you first and foremost, so that you have some leeway, a little bit of a buffer space there.
Mm-hmm. Whole story. I tried Testogel, nothing for 6 months. 2 years later, test inantate 2 vials every 3 weeks, prescribed by my GP. No increase in libido. I had to go to the hospital with blood pressure scare.
Yeah, so you're chemically castrated, my friend. Testosterone enanthate ranges from 4 to 7 days on the half-life, depending on the pharmacokinetics of the individual. And he said once every 3 weeks. Yeah. This is pure malpractice at its finest form. There's no other words to describe it.
He adds, my doctor took me off the test enantate. I am now on hypertension, meds, ramipril, and amlodipine low dose. My hypertension is hereditary. Anyone on TRT with blood pressure meds, he asks. Just trying to
A
get
lot of
libido back.
a lot of people on TRT with blood pressure meds, again, unrelated, although sometimes we can lower their doses of blood pressure meds after they're optimal. You'll never be optimal with an individual who puts you on an anthate once every 3 weeks. You need to fire that provider and find someone competent, which is what I said going back to the beginning of this conversation.
Yeah. Another basic question that wasn't in the first 20 there. Can we achieve a pregnancy while on TRT?
Of course. Of course. Many guys who've been on testosterone for many years, including guys who've abused anabolic steroids, have had children. So never assume that TRT is a form of birth control. Take whatever measures needed as if you weren't on testosterone, if you want to avoid conception.
Something that is interesting, Gil. He adds, can we achieve a pregnancy while on TRT? And he adds, I'm currently on 400 milligrams a week and still have an 800 total T level.
Probably has extremely low SHBG and probably injecting just once a week and then testing a trough. Either way, we know that this is not a proper protocol.
Mm-hmm.
You need to address your SHBG, probably insulin resistance or other metabolic syndromes, and you need to address your frequency. Your provider seems like they may not be up to speed on how this works, to be honest with you. I don't have a single patient out of thousands, not a single one on 400 milligrams a week. And it sounds, again, like low SHBG and improper frequency.
Mm. Our friend Yumer Malik that asked about the iodine. He says iodine around 12.5 milligrams to 50 milligrams for hypothyroidism and to reduce fluoride and bromide toxicity as well as breast cancer treatments.
Well, you have to consider that hypothyroidism can occur for many reasons. It could be a deficiency in iodine, right? In which case supplementation may help. Iodine and selenium may help. And it could also be a pituitary deficiency. And it can also be a pituitary adenoma. And it can also be a thyroid-specific issue, primary hypothyroidism. And until you get a proper diagnosis, it's impossible to implement a treatment plan. So just taking iodine to fix something is not necessarily the answer. Make sure that your thyroid is properly assessed. You may have Hashimoto's, right? Maybe an autoimmune issue, in which case iodine is not going to help you either. You're going to need replacement therapy.
Based on androgen sensitivity and know that everyone will respond differently to dosages, I am at 100 milligrams a week and reach 1000 a peak on twice a week. Would that mean I'm a hyper responder to test?
No, it means you have high SHBG.
Right.
You're binding. That's why your total's high. That's all.
Mm-hmm.
People fail to understand this concept. And I mean, I've explained it in probably a dozen videos. People don't understand the concept of binding proteins and banking your testosterone. Just because it's in the thousands doesn't mean it's all usable.
Mm-hmm. Would it be okay to inject cypionate in the deltoid with a 27G a half inch? Yes.
Not just okay, but advisable.
Yeah, that's it. Yeah, a lot of add-ons and commentaries. I actually had a few other questions, Gil, that I've mentioned or that I noted for you. Let me try those. Well, yeah, a question on SHBG. Can you have high SHBG due to low-carb diets like keto?
Absolutely. Insulin antagonizes SHBG. So when you have low blood insulin levels, SHBG naturally rises. Healthy fats increase SHBGs. So extra virgin olive oil, avocado, nuts, seeds, etc. So oftentimes we'll find in ketogenic or low carb type of individuals that SHBG is elevated.
Mm-hmm. Why does too high of a dose, specifically testosterone, often cause poor sleep patterns and affect quality of sleep? What is the mechanism of action there?
So free androgens, when they're elevated, they may in some people cause upper type symptoms. So think tachycardia, think hypertension, think rapid breathing, think anxiety, think insomnia, think increased metabolic rate, which increases thermic effect and night sweats, irritability, aggression, etc. So you may just have a free androgen level that is a little too high for your own body.
Mm-hmm. How to switch to TRT if one is taking a high dose anabolic steroids? Will my doctor have me stop everything before I can start TRT? How to go about this in the most practical way?
That's a question for your doctor. Personally, I won't treat somebody who's actively doing steroids. But I do have a lot of guys that said, hey, I'm ready to stop this, or I've done this in the past and I need help to feel better and get healthy. We certainly help them. But if you're actively doing this in between treatment, then that's a question for your doctor. But it's not something that we will entertain. It is a liability. It is a risk to yourself. It's a liability to us. And it's not something we treat. Remember, this is medical deficiency replacement. This is not who's going to have the biggest arms.
Mm. But I guess, Gil, a lot of guys that took anabolic steroids are now low in T, so they come to you
Absolutely.
anyway.
Oh, absolutely. I got so many guys in their 40s and 50s said, look, I messed around in my 20s, my 30s. I don't feel good. I want to live long. I want to play with my kids. I want to age gracefully. I want to have energy again. And we certainly help. We certainly, empathize. We don't reject these men. We help them. But if someone is actively going to mess around and deviate from their prescription, they're putting us at risk. They're putting themselves at risk. And again, it's risk mitigation.
I have a lot of low T symptoms with mid-range total T levels, 400 to 600. My doctor prescribed me enclomiphene 25 milligrams every 3 days. What's your opinion on this protocol?
Absolute garbage. Enclomiphene is a selective estrogen receptor modulator. It's going to block the estrogen receptors primarily in the brain. It can also block the receptors in the optic nerve. It can lead to floaters and vision loss over time. It can lead certainly to depression and mood swings. So all clomiphene versions, and the only difference between clomiphene citrate and enclomiphene is 2 isomers instead of 3. So it doesn't have the estrogenic impact of raising serum estrogen, which is kind of moot anyway. They all serums raise SHBG. It will systemically lower free testosterone over time, secondary to SHBG elevation. It's going to paint a pretty picture on labs. So you have this nice piece of paper, to say, hey, look, all my labs look great. But in the real world, it's going to translate into all of these negative symptoms within 6 to 12 months. It is not a lifelong treatment, and I don't suggest it for anyone.
Yeah, I'm not going to ask you why some doctors always start with that. I've heard it here as well.
Ignorant and uneducated about hormones. That's why we do these. We do these because we're trying to put the information out there, the correct information, evidence-based information, anecdotal information, peer-reviewed information. I mean, this is all stuff that is out there. People either refuse to look or they refuse to accept. But either way, we're just going to keep pushing.
I stumbled on a video talking about using Proviron to help counter sexual libido issues while using testosterone and or TRT plus add-ons. Have you heard or explored this with the great team on this channel?
Yes, Proviron is a DHT-derived anabolic steroid non-anabolic. It is a DHT-derived non-anabolic oral steroid that is available in Europe and in South America. It is not FDA approved, sadly, within the US. So, and it's also non-liver toxic, although it does have mild suppressive actions on the HBTA. In conjunction with TRT for men with elevated SHBG who have ruled out liver disease and they cannot get their SHBGs into an optimal range, Proviron 25 milligrams a day has been shown to have a good binding affinity to the protein and therefore helps to free more testosterone. I would not use it, and I would caution against using it as a blanket policy for everyone because guys with low SHBG will cause quite a bit of damage. So rarely would I say, yes, it's good on the select few people. Again, not an option in the United States, so kind of moot here, but I know you have an international audience, so that's my piece on Proviron.
our commenter that asked about being a hyper responder, he says, my SHBG ranges from 25 to 28. What would you recommend for administration frequency for him?
I won't recommend a specific dose and frequency for anyone who's not our patient. However, I will say that that is a fairly nice optimal range. So if he's using 100 milligrams for memory, right, twice a week, in that SHBG in the upper 20s, and he's reaching in the thousands, it's not a hyper responder. He may just be at a height and weight that fits, that level of testosterone. He also may not be using his testosterone, very quickly. He may not be rapidly excreting his testosterone. So enjoy the ride while it lasts. Hey, I'm always a fan of minimal effective dosing to achieve a desired outcome. So why would you want to take 200 milligrams if you can achieve the same outcome with 100 milligrams? The less medication you need to achieve a desired outcome, the better. So don't assume that that's going to stay forever. You may, grow some level of adaptation to this medication over time and have to change dose. Your lifestyle may change, your weight may change. But for the time being, there's nothing wrong, at least in theory, from what I'm hearing about your dosing here. It really comes down to how you're feeling.
Mm-hmm. A related question, because a lot of people hear you talking about SHBG. What is the ideal range for your SHBG?
I hate absolute numbers. Everyone in my office can tell you that, but oftentimes people twist my arm for numbers. 25 to 35 in an otherwise healthy male is a nice spot to be. That's where you're going to find total testosterone and free testosterone to fall within a range of about 2%. So free T will be about 2% of total when SHBG is between 25 and 35. And we find that's where most men find symptom resolution once we dial in their dosing.
I'm having a look at my last blood control, what my SHBG was. 13.
13.
That's low.
It is. Now, it could be a number of things. It could be genetic. It could be some mild insulin resistance. So have a look at your A1C.
I have it somewhere, A1C. Let me have a look. Normally it's around the 5.2, something like that.
Yeah, it's not bad at all. It also could be that you just eat a lot of carbs and you just have high insulin levels. Doesn't mean you're insulin resistant, but you may just have high serum insulin throughout the day, and insulin will antagonize SHBG. And like I said earlier, it could be genetic. But if you feel well, there's nothing wrong with that.
Yeah.
And this is probably why you do well on creams, because if you had high SHBG, the creams would not, you would have no free T on cream. Mm-hmm. You'd have no free T.
Last year, my SHBG was 12. The year before, let's have a look. It's probably 10 even the year before.
So you do eat carbs throughout the day?
Yeah.
Yeah. Well, again, there's nothing wrong with your SHBG if you feel well and you don't have metabolic syndrome. SHBG in and of itself does not mean you're unhealthy. It just means we need to look further. So when I see SHBG in single digits or low teens, the next step is, hey, let's check for insulin resistance. Let's check for obesity. Let's check for markers that bring SHBG there, known markers. And if they're absent, then let it be if you feel well. There's nothing wrong with it.
Yeah.
But you would need increased frequency, which with the cream is not an issue because you're probably dosing twice a day anyway.
Yeah.
But if you were in injections, you may need a daily microdose or at least 3 times a week.
Okay.
Otherwise, you'd be excreting very rapidly. You have no binding affinity.
All right, I understand. Last questions, guys. Almost an hour. Just got my blood work back. I'm at 606 total tests, but I still have symptoms of low T. My doctor is going to prescribe me 80 milligrams a week and go up from there. Will 80 milligrams a week have a negative effect?
Okay. In rare cases, it's sufficient. Rare cases, generally, it's too low of a dose. It certainly cannot be once a week. That would always be flawed. And secondly, I did not hear his SHBG. And I'm going to step out on a limb here and say that it wasn't tested. And if it wasn't tested, please don't start. Do not pass go. Do not collect $200. Move right on to the next provider who understands how to do this. I need your luteinizing hormone. I need your SHBG. And I need your age.
anyone who came with symptoms like erectile dysfunction and or low libido, and no matter what, can you help him?
I mean, sure, we can help. If I had an individual in my office, I'd run through the proper assessment in order to determine the etiology behind his ailments, and we would certainly help. I mean, we see over a dozen men every single day in our office with similar symptoms. So the short answer is yes, we can help.
Yeah, talking of that, Gil, how can people reach you if they want to contact you?
So the best way would be to go to nextleveldietetics.com. If you're looking for a consultation over the phone for 30 minutes, if you live in the United States, and this is for US-based individuals only, and you'd like to be considered for telemedicine treatment over the phone, then you go to elevatewellnessgroup.com and you fill in your name, phone number, and email address. Select telemedicine from the drop-down menu. You'll get a call from my office explaining the entire process to you. And we can have labs done at your local lab facility in whatever state you live in. We can have a pharmacy ship medication directly to your door, and we will speak to you on the phone periodically in order to do lab reviews and guide you on your treatment. You're also free to call the office at any time in between your lab reviews should you have questions for your provider. So this is all going to be explained to you. The first step is just go to elevatewellnessgroup.com and fill in your name, phone number, and email. My office will call you within 24 to 48 business hours, and they will answer all questions you have. There's no cost to do this unless, of course, you begin treatment, but there's no cost for this phone call from the office to answer questions. So there's no harm for anyone in the U.S. to at least have it done just so you have a little more information.
All right, Gil, thank you so much, as always. We appreciate you doing this. A lot of people are thanking you in the comment section as well. So, all right. So
it's a pleasure. Thank you. It's been a while. It's good to see you, Stephen. Thank you.
Yeah, same, Gil. All the best.
Right. Happy holidays. Bye-bye.